Ventricular hypertrophy. Ventricular enlargement is diagnosed from the pattern and amplitude of the QRS complexes in the chest leads V1 to V6. This is the normal pattern of QRS complexes in chest leads. The lead V1 shows a small R wave and a deep S wave. As we proceed towards V6, the height of R wave progressively increases and depth of S wave progressively decreases. Somewhere in V3 and V4, the R and S waves are equal, and in V6 there is a tall R wave and very small or absent S wave. This ECG shows a normal QRS pattern in the chest leads. Note the S wave in right-sided chest leads which disappears as we reach V5 or V6. R and S are equal in V4, and the R wave progressively increases from V1 to V6. In left ventricular enlargement, this pattern remains the same, but the amplitude of the waves increases. This is the normal pattern. Now in left ventricular hypertrophy, note that there are deep S waves in V1 and V2. R and S waves are equal in V3, and there are very tall R waves seen in V5 and V6. That is, in left ventricular enlargement, there is normal progression from negative deflection in lead V1 to positive deflection in lead V6, but the amplitude of the waves increases. So we have to measure the amplitudes of S wave in leads V1 or V2, whichever is larger, and amplitude of R wave in V5 or V6, whichever is larger, to diagnose left ventricular hypertrophy. If any of these is more than 25 millimeters, SV1 or RV6, or if their addition is more than 35 millimeters, then a diagnosis of left ventricular hypertrophy is made. It will usually be associated with left axis deviation, and a P mitrale of left atrial hypertrophy may be seen in lead 2. In this ECG, there is normal pattern of QRS complexes from negative in V1 to positive in V6. So let us measure SV1 and RV5 from the isoelectric line. SV1 is 19 millimeters and RV5 is 18 millimeters. SV1 plus RV5 is 37 millimeters, that is more than 35 millimeters. So left ventricular hypertrophy is present. This is another ECG where gross inspection of the chest leads immediately reveals that the amplitudes of QRS complexes is very high, but there is normal progression from negative deflection in V1 to positive deflection in V6. Now measure the amplitudes. SV1 is 21 millimeters. RV6 is 25 millimeters. So SV1 plus RV6 is 46 millimeters, which is more than 35 millimeters. So left ventricular hypertrophy is present. In this ECG, again note the normal progression from deep S waves in V1 to tall R waves in V6. SV2 is 28 millimeters, more than 25 millimeters. So left ventricular hypertrophy is diagnosed. RV6 is 25 millimeters. So SV2 plus RV6 is 53 millimeters, all in support of left ventricular hypertrophy. Now observe leads 1 and 3. Left axis deviation is seen with positive QRS in lead 1 and negative QRS in lead 3. Now study the P wave in lead 2 shown enlarged in the inset. It is 2.5 small squares wide, suggesting that there is left atrial hypertrophy also. Right ventricular hypertrophy. In right ventricular hypertrophy, the pattern of the QRS complexes in the chest leads will be changed. This is the normal pattern from SV1 to RV6. Let us now compare and study the pattern of right ventricular hypertrophy. In right ventricular hypertrophy, lead V1 shows a prominent R wave. Lead V2 also shows a prominent R wave. Leads V3 and V4 are similar with equal R and S. Lead V5 shows a deep S wave, and lead V6 again shows a prominent S wave. So whenever there is a prominent R wave in lead V1 or deep S wave in V6, right ventricular hypertrophy must be suspected. The criteria for diagnosis of right ventricular hypertrophy are R wave in V1 more than 7 millimeters, or S wave in V5 or V6 more than 7 millimeters, or addition of both more than 10 millimeters. Right ventricular hypertrophy may or may not be associated with right axis deviation, and often there will be P pulmonale of right atrial hypertrophy. In this ECG, V1 shows a tall R wave, taller than S wave. So immediately think of right ventricular hypertrophy. There is a corresponding deep S wave in V6. So the normal QRS pattern in the chest leads has altered. Now measure RV1. It is 11 millimeters. RV1 more than 7 millimeters is diagnostic of right ventricular hypertrophy. SV6 is 5 millimeters. Their addition is 16 millimeters. More than 10 millimeters is the criterion for right ventricular hypertrophy. Now come to limb leads. There is no gross deviation of axis, but there is a negative wave in 1 and AVL and positive wave in lead 3, suggesting tendency to right axis deviation. Now note the P wave in lead 2. A very typical tall and peaked P pulmonale is seen in leads 2, 3 and AVF, diagnostic of right atrial hypertrophy. So this ECG shows right ventricular hypertrophy with right atrial hypertrophy and right axis deviation. The next ECG shows a prominent R wave in V1 and a deep S wave in V6. So right ventricular hypertrophy is suspected. Let us measure the amplitudes of RV1 and SV6. RV1 is 6 millimeters. SV6 is 16 millimeters. RV1 plus SV6 is 22 millimeters. So the criteria for diagnosis of right ventricular hypertrophy are met with. Coming to limb leads, negative QRS in lead 1 and positive QRS in lead 3 denotes right axis deviation, and P wave in lead 2 is broad, suggesting left atrial hypertrophy. This ECG shows a prominent R wave in V1 and deep S wave in V6, that is a change in the QRS pattern. RV1 is 9 millimeters, more than 7 millimeters, and SV6 is 7 millimeters. So RV1 plus SV6 is 16 millimeters, that is more than 10 millimeters. So right ventricular hypertrophy is present. Now look at the limb leads. Imagine lead 1 above and lead 3 below. Right reaches. So right axis deviation is present. And the P wave in lead 2 is wide as well as tall, suggesting biatrial hypertrophy. Strain pattern in ventricular hypertrophy. Ventricular enlargement is of two types, dilatation and hypertrophy. When the left ventricle has to work against resistance, as in hypertension or aortic stenosis, there will be hypertrophy of its muscle, which will be seen on the ECG as strain pattern in leads V5 and V6. In addition to the very tall R waves, the ST segment is slightly depressed and the T wave is inverted. This is the strain pattern that indicates hypertrophy of left ventricle. In this ECG, the strain pattern is seen. Note the very tall R waves, slightly depressed ST segment and inverted T wave. This ECG shows left ventricular hypertrophy without strain, as in aortic regurgitation or mitral regurgitation. Note the tall R wave of left ventricular hypertrophy. but normal ST segment and upright T wave. This ECG with left ventricular hypertrophy in leads V5 and V6 shows mild strain. ST segment is depressed slightly and T wave is reduced in amplitude but not inverted. This is another case of left ventricular hypertrophy, and note the strain pattern: depressed ST segment and inverted T wave. A similar strain pattern may be seen in right ventricular hypertrophy due to pulmonary stenosis. Leads V1 and V2 will show depression of the ST segment and inversion of the T waves. In this ECG, leads V1 and V2 show prominent R wave of right ventricular hypertrophy and strain pattern with ST segment depression and T wave inversion. Now this ECG shows biventricular hypertrophy. Note the tall R waves in V1 of right ventricular hypertrophy, and also note the deep S wave in V1 and V2 with tall R waves in V5 and V6 of left ventricular hypertrophy, and the strain pattern in V5 and V6. RV1 is 10 millimeters, so right ventricular hypertrophy is present. SV2 is 24 millimeters. RV5 is 22 millimeters. Their total is 36 millimeters. So left ventricular hypertrophy is also present with strain. Once again, note the picture of biventricular hypertrophy: RV1 of right ventricle, SV1 and V2, and RV5 and V6 of left ventricle with strain pattern. Note again in close-up RV1, SV2, tall R waves in V5 and V6 with strain pattern.